Today we are talking about a very important and commonly encountered inpatient problem that's equally important to physicians, nurses, and respiratory therapists. How to respond to a hypoxic patient in real-life practice is the topic today. Let's first all agree that hypoxia is a medical emergency that needs immediate attention. You leave everything in your hand and go see your patient immediately. Agree? In today's video, we are going to discuss how to recognize hypoxia in its early stages first, then how to stabilize these patients, then we finish by how to investigate and treat the underlying problems. Today's video is full of important information throughout the whole video, so make sure to watch to the end. I have no doubt it will help you save lives. I will be using hypoxia and hypoxemia terms here interchangeably during the video. Difference in definition here doesn't matter much. Let's go to our little studio and start. Most crashing hypoxic patients had shown warning signs of earlier, milder hypoxia before they crash. The detection and treatment of these early signs do save lives and prevent the significant morbidity associated with hypoxia. So how do I smell hypoxia in its early stages? Remember that oxygen saturation reading is an essential part of vital signs and must always be mentioned along with whether on room air or O2 supplements and how much supplements the patient is on. Why that's important? Take a look at patient A and patient B here. Patient A O2 sat is 96% on 10 liter per minute of nasal cannula. Patient B O2 sat is 92% room air. You can clearly see that patient A is worse than B despite the O2 sat of patient A being better than B. So never accept pulse oximetry reading without knowing whether on room air or on oxygen supplements and how much oxygen supplement. One of my, if I can say, rounding reflexes is to see if my patient is on any oxygen supplements, how much, and ask the patient whether he or she uses home O2 and if yes, how much O2 they use at home. Usually I'm happy as long as my patient's room air O2 sat is equal or above 95% or at baseline home oxygen. But as soon as I see one of the following condition, I must know why and try to treat any underlying issue as soon as I can. Room air O2 sat that's less than 95%. A patient who is not on home O2 and now is requiring O2 supplements to maintain O2 sat at or above 95%. Or a patient who is using home O2 and now is requiring more compared to the home baseline. This way you can prevent most patients from crashing secondary to untreated progressive hypoxia. You literally save their lives. We also need to be careful when the nurses call us about any oxygenation issue. They may not directly tell us there is a problem with oxygenation, as similar to physicians, nurses don't have the same level of experience and may not feel the sense of urgency when they call us. Let me give you some examples of what might they tell you over the phone. Hey doc, I'm having a hard time keeping the patient O2 saturation up. I have to increase his oxygen all the way up to 8 liters per minute, but he's doing better now. Hey doc, nothing urgent. I forgot to tell you that I have to crank the patient's O2 a bit up, but he's doing okay now and his O2 sat in the 90s. Hey doc, my patient's O2 sat dropped to low 80s a while ago. I put him on 2 liters per minute and it quickly improved to 92%. I just wanted to let you know. And of course, they may tell you straight to come and see the patient immediately because of very low oxygen saturation. With all these scenarios, I always ask the nurse about the current exact pulse oximetry reading, how much O2 the patient is on, a full set of vital signs, and how's the patient feeling. And I go and evaluate my patient right away. Always better safe than sorry. Now take a look at these quick clinical scenarios and see if you feel reassured or not. I'm sure you got all of them right. Hang on, answers will be provided at the end of this video. Now, the moment I suspect, smell, or know my patient is hypoxic, I have to correct this hypoxia as soon as possible. There are two types of patients here. The patients whose nurses have already increased their O2 supplements and their O2 sats are already above 92%. They are asymptomatic and the rest of their vital signs are stable. These patients are already stable but still need to be evaluated as soon as we can to find out why they are requiring O2 supplements to prevent further clinical deterioration. The second type, of course, are the patients who are unstable, their O2 sat is low, they are symptomatic, and the rest of their vital signs are unstable. This is a medical emergency, so leave everything and run to the patient. Over the phone, I tell the nurse to crank the patient's O2 supplements up to the maximum amount of the immediately available oxygen delivery device. At the minimum, the patient should be placed on the 100% non-rebreather mask. If the patient is already on BiPAP, CPAP, or high-flow nasal cannula, I tell them to increase FiO2 to 100%. Remember to activate the rapid response team if you have it at your hospital to speed up the response to your patient. As soon as I enter the room, I make sure the patient is on the maximum amount of oxygen supplements available at the bedside. The patient is on a monitor, the crash cart is at the bedside, and the pads are on. And if rapid response teams is activated, all of that should be automatically done for you. Listen to this. Please proceed with endotracheal intubation and mechanical ventilation if hypoxic respiratory failure is associated with encephalopathy, whether the patient is agitated, lethargic, or obtunded. Don't forget to start bagging the patient immediately if extremely lethargic or obtunded. And second, if the patient keeps vomiting with recurrent aspiration. In these two conditions, don't think twice, just intubate them. If the patient is not encephalopathic, we need to quickly act to prevent further deterioration and avoid mechanical ventilation if possible. Please take a quick listen to the patient's lungs if feasible, look for any fluids or blood products that are hung, and simultaneously get a quick brief history from the patient nurse, and I then stand in front of the bed so I can run the show. Again, this should be done in less than 30 seconds, believe it or not. If the patient oxygen saturation is still less than 90 to 92%, then proceed to the maximum level of oxygen delivery available. What do I mean here? At my facility, we have the high-flow nasal cannula, CPAP, and BiPAP. All can provide 100% FiO2. Now, which one to pick depends on the underlying process. Pick BiPAP or bilevel positive airway pressure over CPAP and high-flow nasal cannula if there is concomitant hypercapnia confirmed by ABG or even suspected hypercapnia like in patients with COPD and obesity hypoventilation syndrome until the ABG result is back. Pick CPAP or high-flow nasal cannula if pure hypoxia without concomitant hypercapnia. CPAP is preferred if respiratory distress and increased work of breathing. And high-flow nasal cannula is preferred if the patient cannot tolerate the mask or some facial injuries or high risk for aspiration. Now, practically in that very moment, picking any device should be acceptable. So if you are stressed out and your heart is pounding and cannot think much, just pick BiPAP and you should be okay until the patient is more stable. I'm less worried about inappropriately washing out CO2 in this acute phase. Hypocapnia is not going to kill the patient, but hypoxia will. Now, what settings should we use? Regardless which device to use, all patients should be initially placed on 100% FiO2. In high-flow nasal cannula, we need to provide the flow rate as well. The maximum flow rate varies depending on the machine brand. In our hospital, we have what we call Vapotherm with a maximum flow rate of 40 liters per minute. So please use the maximum flow rate along with the maximum FiO2. In CPAP, we need to provide the initial CPAP value as well. 10 cm H2O is a good starting CPAP value. In BiPAP, we need to provide the EPAP value, which is the equivalent of CPAP, and the IPAP, the inspiratory positive airway pressure values as well. 10 cm H2O is a good starting EPAP value in BiPAP. How about the IPAP value, which is the inspiratory positive airway pressure? Initially, I like to set it to have a peak inspiratory pressure 5 cm H2O above the EPAP value. I usually pick 5/10, which means an EPAP of 10 cm H2O, and to add 5 cm H2O during inspiration making the peak inspiratory pressure at 15 centimeter H2O. There are two ways to improve oxygenation: a quick way by increasing FiO2 and a slow way by increasing the flow rate in high flow nasal cannula, the CPAP value in the CPAP machine, and the EPAP, the expiratory positive airway pressure, in the BiPAP machine. Remember that only BiPAP machine can help with ventilation given the gap between the IPAP and EPAP, the ventilation pressure. Now, very important to remember that O2 sat or oxygen saturation may not improve instantly. Don't panic, it may take more than just a few minutes to start creeping up. As long as the oxygen saturation or the PO2, if you're doing an ABG, is steadily improving, then we should be happy. Also consider increasing the CPAP or EPAP value if already on CPAP or BiPAP machine by 2 to 3 centimeter H2O increments. Remember to adjust the IPAP value to keep the peak inspiratory pressure at least 5 centimeter H2O above the EPAP value, the expiratory positive airway pressure. Remember, at any point the patient becomes encephalopathic to proceed with endotracheal intubation. Now you may be asking when to consider intubation and mechanical ventilation in patients who are not encephalopathic. The decision to proceed with mechanical ventilation is not always clear-cut. Multiple factors need to be considered, including code status, mental status, and hemodynamic stability. In general, we should strongly consider mechanical ventilation if the patient O2 sat remains less than 80% despite maximum oxygen support without any signs of clinical improvement. Now, during COVID era, I have to be honest with you, we had patients with O2 sat in 70s and did not intubate them, and they got better eventually. So use your clinical judgment and whether the patient is improving or not. Let me give you an example. Let's take a look at these two patients. Patient A initial O2 sat was in the 40s, but as soon as he was placed, let's say on CPAP, at this value, 10 centimeters to and 100% of IO2, his O2 sat started to progressively improve. Now he's in the high 60s and creeping up. This patient, I will definitely give him more time. Likely he will continue to improve. On the other hand, patient B initial O2 sat was in the low 80s, but continued to decline despite CPAP of 10 and 100%. He's dropping to 60s, then 50s. This patient will need to be intubated and placed on mechanical ventilation. It's clear cut. Now, if you are in doubt, don't hesitate to ask the people around you if we should proceed with intubation or not, including your colleagues, nurses. Just get their opinion. Now, simultaneously, while trying to stabilize the patient's oxygenation, we are at the same time trying to figure out what's going on. As I mentioned earlier, we get a quick history from the patient's nurse, take a quick listen to the patient's lungs if feasible, inspect the room for any hung IV fluid or blood products, and order a stat chest X-ray, EKG, and ABG. Let's take a break here. A lot of info so far, huh? You probably studied hypoxemia pathophysiology and the 5 mechanisms of that. Hypoventilation, VQ mismatch, right to left shunt, diffusion limitations, and low inspired FiO2. I mean, we could go over these and all the possibilities, but I want to talk about the most commonly encountered condition that can cause acute hypoxic respiratory failure in clinical practice. Listen to this, please. Most of the patients who develop sudden shortness of breath and severe acute hypoxic respiratory failure in the hospital have one of the following conditions: pulmonary edema, whether cardiogenic or non-cardiogenic, PE, aspiration pneumonia, pneumothorax, lung collapse or atelectasis, and large amounts of pleural fluid collection, whether this secondary to a pleural effusion, empyema, or hemothorax. Now let's go back to the studio to finish. Think of pulmonary edema if the patient is orthopneic, crackles are appreciated on the lung exam, JVD is seen, and peripheral edema as well. Also, you may see IV fluid or blood products are hung. Here, I immediately stop any IV fluid or blood products infusion and give a high-dose loop diuretics. I commonly use 80 mg of IV furosemide. CPAP machine is the best for pulmonary edema if no associated CO2 retention issue, and I initiate nitroglycerin drip if blood pressure is high. Make sure to review the EKG and chest X-ray, of course the ABG as well. Get cardiac enzymes and obtain an echocardiogram, please. If choking was reported by the patient's nurse or evidence of vomiting around the patient's mouth or on the bed, then think of aspiration as a cause of hypoxia. As mentioned earlier, if they keep vomiting and aspirating, go ahead and intubate them. Don't hesitate. High flow nasal cannula with maximum settings should be initiated in such case. CPAP and BiPAP can be used, but it may worsen the aspiration if the patient keeps vomiting or unable to clear secretions. Placing NG tube and connected to suction may not be a bad idea in such a case, and allow us to use CPAP and BiPAP with less concerns of worsening aspiration, as long as the patient is alert enough and able to cough his secretions out. Don't forget to initiate antibiotic in such a case. If there are absent breath sounds on one side, then think of pneumothorax, atelectasis, or a large amount of fluid in the pleural space. Get a chest x-ray immediately to confirm your diagnosis. Luckily, in our facility, they are usually waiting outside the room when rapid response team is activated. If large pneumothorax confirmed on the chest x-ray, a chest tube should be placed immediately. Tension pneumothorax patients usually hypotensive and tachycardic with JVD as well on the exam. In reality, these patients, we still get a chest x-ray and insert a chest tube immediately. Now, proceeding with needle decompression of the pleural space is recommended if there will be any delay in inserting the chest tube. The concern that CPAP or BiPAP worsen pneumothorax can be reduced or eliminated once chest tube is placed. If any concern, maximum high flow nasal cannula can be used initially until chest tube is placed. Now, complete or near complete lung whiteout on chest x-ray will either suggest atelectasis or large pleural space collection. Tracheal shift and history should help us differentiate between both. A patient who is having weak cough and difficulty clearing respiratory secretions likely will have atelectasis. Tracheal shift in such a case usually toward the affected side. Initiate CPT, frequent suction, breathing treatment, and mucolytics. Also consult pulmonary for possible bronchoscopy if no improvement with the conservative measures. Now, tracheal shift toward the unaffected side suggests a pleural space collection with a pleural effusion, empyema, or hemothorax. Think of pleural effusion if underlying active malignancy, liver cirrhosis, or heart failure. Empyema patients are usually sick with pleuritic chest pain and severe or significant or severe leukocytosis, fever sometimes. Think of hemothorax if recent trauma or recent thoracic procedure while on anticoagulation or even without anticoagulation. Therapeutic thoracentesis should be performed preferably with chest tube placement. Pulmonary embolism PE is usually suspected if the patient's hypoxia is not explained by the patient's lung exam and chest x-ray finding. Let me give you an example to make it clearer. Take a look at these two patients, A and B. These are their baseline chest x-ray. Patient B uses 2 liters per minute at baseline at home. Both develop shortness breath and hypoxic respiratory failure. Both currently requiring high flow nasal cannula at 40 liters. Flow rate and 85% FiO2 to keep their O2 sat above 90%. These are their repeat chest x-ray. You can see that patient A chest x-ray is much worse compared to baseline, and it does explain the patient's symptoms. While patient B chest x-ray looks almost the same despite it's abnormal to start with, but it has not changed compared to baseline. To me, it does not explain why the patient is short of breath and more hypoxic. PE or pulmonary embolism should be ruled out. If the suspicion is high and no contraindication, full anticoagulation should be started as soon as possible. A stat chest CTA should be performed, but remember that patient should be stable enough to undergo this CT. Bedside point-of-care ultrasound can be very helpful in establishing the diagnosis if you are trained to use it. In all of these patients, keep them in PO until they are more stable. If aspiration was the culprit, then obtain a speech therapy evaluation. Move these patients to a higher level of care, usually ICU. Intermediate care or step down can be an acceptable option in some patients. A rainbow of blood work usually ordered, including CBC, CMP, cardiac enzymes, and lactic acid. Further workup and treatment may be warranted. Let's say the EKG showed evidence of an acute MI, then treatment guidelines should be followed accordingly. Make sure to order a follow-up ABG and adjust your treatment accordingly. When FiO2 down as tolerated, don't lower the flow rate of the high flow nasal cannula, the CPAP value in the CPAP machine or the EPAP value in the BiPAP machine until the FiO2 requirement down to 60%. Then I start winning both together. I hope you made it through to the end of this video.